Hi, in this video, I'm going to talk about inflammatory breast cancer. What is it? How do we diagnose it? And how is it treated? Before I go on, I'd love to invite you to subscribe to our channel. We put out about 3 new videos a week, so there's always new information to come back to. Inflammatory breast cancer is actually a pretty rare type of breast cancer. We see it in about 1 to 5% of people with breast cancer. It is more common in Black women, so that's important to know. Inflammatory breast cancer is a term we use to describe breast cancer in which the breast is affected throughout the skin and throughout the entire breast tissue, even without a mass. So I'll describe what this looks like. Inflammatory breast cancer shows up in one of several different ways, and there are some very specific criteria that need to be met in order for this to be called inflammatory breast cancer. So the changes I'm going to describe need to be present on more than half the breast. So if just one patch of the breast fits the description I'm going to give you, that is not inflammatory breast cancer. So what are the changes we look for? In general, we see a red, swollen, heavy breast. This can be bilateral, that's less common. So in general, we will see one very heavy red breast with a lot of swelling of the skin. The way this shows up is those pores on the skin don't change, but the skin itself gets inflamed. What this looks like is the peel of an orange, and the term that we use is peau d'orange, which is French for the skin of an orange. And a lot of us don't know French, so it's one chance for us to get to practice. But this is what you'll see on the breast or hear people describe. Now, not all of those changes need to be present. And I have to tell you, sometimes we can't tell the difference between a bad infection of the breast, like cellulitis, which is inflammation of the soft tissue, or inflammatory breast cancer. And it's quite common that people will come to an oncologist or a breast surgeon once they've been on antibiotics for a little while. Because it's so rare, and because other things are more common, like cellulitis or inflammation of the soft tissue of the breast, many women will have been on 1 or maybe even 2 courses or weeks of antibiotics before they end up being sent to a surgeon who makes the diagnosis or a multidisciplinary team. As I mentioned, these changes need to be present on the majority of the breast. And the other important distinction is that they need to have shown up over quite a short period of time. So there are some people who will develop changes like this in the breast over many, many months to years. And for whatever reason, they don't seek medical attention. That's very different from inflammatory breast cancer, where the changes come up over just a number of short weeks or even days. I mentioned before that inflammatory breast cancer often does not have a breast mass. So it's not that one needs to feel a breast mass or lump to be able to say this is inflammatory breast cancer. So how do we diagnose it? Well, we will do breast imaging because there are enough times where we do see a lump or mass that we can then biopsy. The other way we can diagnose inflammatory breast cancer is by doing a skin biopsy, though this is negative up to half the time. In other words, no cancer cells are seen in the skin. The skin's sort of circulation is blocked by the cancer cells, but that doesn't mean where the biopsy is done will necessarily find the cancer cells themselves. So really, inflammatory breast cancer is a clinical diagnosis. A mammographer cannot tell you this is inflammatory breast cancer. They can tell you the skin is thickened on mammogram, but they don't know over what time that developed. They can tell you that there's pulling back of the skin, sort of puckering of the skin, but they can't tell you how quickly this developed, They can rule out a mass on imaging. Oftentimes people will head to an MRI because we want to find something that we can biopsy to confirm a clinical concern of inflammatory breast cancer. So we do try very hard to make a diagnosis before we treat somebody as if they have cancer. And if we're not certain, as I mentioned earlier, we will treat them with an antibiotic, a broad spectrum antibiotic, to make sure this isn't merely a skin infection. Even experienced oncologists can have a difficult time making the distinction between inflammatory breast cancer and a skin infection. One other thing that can help is to look at the lymph nodes. Inflammatory breast cancer is rare, and you will often see the word aggressive attached to it. People more often than not have positive lymph nodes. So another place to go for a biopsy to confirm this is cancer is to look at the lymph nodes. And that's often the source of both the tissue for diagnosis and also for looking for things like estrogen receptors, progesterone receptors, and the HER2 status. So how do we treat inflammatory breast cancer? Well, we start by making as good a diagnosis as we can. And then because this cancer tends to travel early, we do imaging of the rest of the body with a CAT scan of the chest and abdomen. One does not need to have a CT scan of the pelvis, and we do a bone scan. Some people might get a PET CT scan depending on the availability or the practice of the doctors in the area where you are practicing. What we're looking for when we do those scans is to see if the cancer has spread to other parts of the body. If it has, we still treat it, but the goal of treatment is different. At that point, the cancer is stage 4, and although we hope for a cure and we treat people very aggressively with lots of different treatments together, the goal at that point is to prevent problems down the road, keep the disease under control as best as possible. So once you're diagnosed with probable inflammatory breast cancer, you would most likely have scans to look in the chest and the abdomen and also at the bones. If you're having symptoms like headache, visual changes, or weakness, it's also very likely that you'll have an MRI of the brain as well. We want to kind of know the enemy. We want to know what we're dealing with. You want to know what you're dealing with, and then we can outline a treatment plan. Even if the cancer has spread to other parts of the body, inflammatory breast cancer is generally treated with chemotherapy first. We generally do not do surgery first because the cells have tracked their way along under the skin, and it's very hard to get clean margins. So if we were to do a mastectomy, remember most of the breast is involved, it is very likely after a mastectomy that cancer will recur in the surrounding skin and then infiltrate back into, if you had a reconstruction, back into the reconstructed tissue, or just all over the chest wall. It can even cross the midline to the other breast. So chemotherapy and, if appropriate, targeted therapy if the tumor is HER2 positive, or if you're on a clinical trial. And we treat systemically because we're treating not just the rest of your body for any cells we might see or might be concerned are there, but we also want to see the disease receding in the skin and coming in so that the surgeon can get good margins when the surgery is done. That's generally the next step. Surgery will be done to remove the breast. Some people, after chemotherapy and targeted therapy, if appropriate, can have breast conservation after inflammatory breast cancer. We used to say this was a no-no, but if one has a really good response to treatment, and especially if we know we saw the primary tumor, breast conservation can be attempted, followed by radiation therapy. Radiation therapy will be part of the treatment plan even if one has a mastectomy. After inflammatory breast cancer surgery, radiation therapy is nearly always recommended. There would be a couple of exceptions that I won't go into now. If you were one of those exceptions, feel free to drop a comment below. But in general, systemic therapy with chemotherapy, with or without targeted therapy, then surgery, which is removal of the breast and the neighboring lymph nodes, radiation therapy. And for some people, if there was enough disease left in the breast at the time of surgery, you would actually be offered, possibly, depending on the features of the tumor, additional chemotherapy before radiation therapy. We do try not to delay the radiation therapy, so you may actually have a discussion about, should you do radiation first, then the additional chemotherapy. So these are all the treatment modalities. With inflammatory breast cancer, systemic therapy first, then local regional therapy, maybe more chemotherapy, depending on how much tumor is left after the first set of chemotherapy. If the tumor was estrogen and progesterone receptor positive, hormonal therapy is part of this. And most targeted therapy continues long after the surgery. So depending on how much targeted therapy you've had, we usually aim for about a year. There's some clinical trials with longer durations, but a year is pretty standard. I've covered a lot. I do want to mention that, as always, if you have a strong family history of breast or other cancer, make sure you tell your medical team, because we can do testing to see if you inherited a susceptibility to cancer. And as always, we have a wealth of videos that you can watch that cover pretty much everything I've talked about during this video. Drop us a comment or question below. While I can't give specific medical advice, I will answer your question to the best of my ability. Don't forget to subscribe, and if this video was helpful, like this video. Thanks for watching.